Good morning, good afternoon, or good evening, depending on where you're joining us from today. My name is Natalie Giacondo, the former president of MPN Advocacy and Education International. And we are here for this first time NPN workshop of the Carolinas online. So we've hosted this workshop before in person, but we listen to our um, patients and families, and we decided to host this online to be able to give access to more people. And we actually have almost 400 people registered today. So we welcome all of you, and we'd like to thank our MPN specialists for taking time out to join us today, and also our industry partners who we will hear from at the end of our conference today. So I welcome you, and I would like to start off by allowing Dr. Michael Grunwald to say a few words about this conference.
Yes, thanks, Natalie. So welcome everyone. I'm Mike Grunwald from Atrium Health, Levine Cancer Institute, and Wake Forest University School of Medicine. And usually my colleague and mentor, Dr. Ruben Mesa, would do this welcome, but he's going to be joining us a little bit later today. I think it's very important to engage the community of providers, researchers, clinical investigators, supporters, patients, and caregivers in the Carolinas. And I think that this forum, which has existed in this way for about 3 years, has been terrific. We've had a lot of great questions from patients, a lot of participation, and I've learned a lot of things from colleagues as well as from the audience. So thank you all for being here, and we will get started. We've got a number of 15-minute talks, and my colleague from Medical University of South Carolina, Dr. Alexander Coltoff, is going to be our first speaker. So without further ado, I will hand it over to him and he will share his presentation.
Thank you, Mike. Thanks, Natalie, and everyone for putting this on. And thanks, everyone, for being here. 400 people. I'm a little nervous, I gotta say. Okay. Let me see if I could share my screen. Just please, someone feel free to unmute and let me know if you can't see it or if it's not advancing. But like okay. Like Dr. Grummel said, I'm at the Medical University of South Carolina, and it's maybe nice to see some people I know in the audience. Maybe if I have not met you, it's nice to meet you. So I was asked to talk today just to give a brief overview about the diagnosis and kind of monitoring for MPNs. And I'll try and keep it brief and give a kind of just general overview, I think, without trying to replicate too much of what my colleagues will be talking about for specific MPNs over the next 2 hours. From a kind of 10,000 foot view, what are MPNs? They're definitely a mouthful, but they stand for myeloproliferative neoplasms. And essentially, they're a group of chronic blood cancers that share some common features. For the most part, they all kind of result from an overproduction and overactivity of your blood cells. And these are more evident in some MPN subtypes. For example, Polycythemia vera will often have high red blood cells and potentially high white blood cells and platelets. ET will often have high platelets. Myelofibrosis, I had a little asterisk there next to the white blood cells. That can go high or low.
Dr. Koltoff, I hate to interrupt you, but we were seeing your slides before, and now I don't seem to be seeing them again. So just want to make sure.
Okay, let me try again.
Okay.
Sometimes if I share my, let's see, is that working?
Yep, we got him now. Thanks.
Okay, okay. Is it gonna happen again? Let me know if it happens again.
It
Because
happened again. As soon as you like moved it.
yeah. Let me see.
There we go. We can see him.
Okay. It keeps happening when I play from current slide. Let me just see. Is that okay
There we
still?
go. Yep.
Okay. Great, let me just minimize this. Okay. Um, so this overproduction of blood cells is common for all three. Symptoms are a large part of the disease or cancer for many people, and they could be really the predominant kind of thing that has impact on quality of life. And those can be non-specific things like night sweats or weight loss, or symptoms related to a large spleen, or to blood counts, like for say bleeding or bruising if you have low platelets. And all of the MPNs share some risk of developing acute myeloid leukemia, which is an acute blood cancer that generally needs immediate treatment. I should say too, the term chronic blood cancer sometimes is a little bit confusing and also sometimes a little bit of a misnomer. There are situations where um, you might have an MPN that needs more immediate treatment or even more aggressive treatment. But by and large, compared to some other types of blood cancers, these are things that are dealt with in the clinic, outside the hospital, and over the course of years and hopefully decades of stability. All MPNs can cause some scarring of the bone marrow as well. This is kind of sine qua non of the diagnosis for myelofibrosis, but can be seen in polycythemia vera and essential thrombocythemia as well, and um, exists on a spectrum. It's not sometimes as easy as is there scarring or not, and that's a important conversation to have with your doctor. And then we'll talk about this in the next couple of slides, but MPNs also share this kind of activation of this light switch in your bone marrow that tells it to either make more blood cells or not. And this is called the JAK-STAT pathway. And I'm sure many of you have heard the term, JAK-STAT or JAK or are on medications that have those three letters in them, the JAK. So let's talk about what that means. Again, a very kind of big overview. So without getting too much into kind of college biology here, you can think about everything kind of below this green line here as inside of the cell. And the way that your bone marrow works is it has these young blood cells, and they either get a signal or they don't get a signal that tells them to kind of make more of themselves and increase blood cell production. Essentially, a factory getting a signal to make more products. And this signal is some kind of chemical messenger. This is an example of when the blood cell does get that signal. Then these proteins in the cell, JAK and STAT, basically work to ramp up production. And so under normal conditions, if you're getting the green light to make more blood cells, um, the footsteps on the gas, and if you're getting the red light, the footsteps on the brake, right? And so this is how blood cell production is supposed to work. Essentially, you're only kind of stepping on the gas when this signal is there. With MPNs, there's an abnormal functioning of this kind of signaling pathway. So uh, here's an example of a blood cell that does not get a signal from outside to make more blood cells, but because of this pathway, there's some error in it. These proteins are always turned on. The result is to increase red blood cell production or blood cell production without getting a signal. And so in MPNs, essentially, regardless of a green or red light, this pathway is always turned on, and there's this increased activity in the bone marrow. And this is essentially what we mean when we say that there's a JAK mutation or another one of these common mutations in the bone marrow. So the types of MPNs are variable, but when we talk about the kind of MPNs in this 2 hours and in general, we're talking about MPNs that are in green here. So CML or chronic myeloid leukemia is an MPN that results in increased white blood cells, and um, it's treated differently than the other three here. So today you'll be hearing talks mostly on polycythemia vera, essential thrombocythemia, and myelofibrosis. And as you can see from this diagram, ET is largely characterized by an increased number of platelets, PV, primarily characterized by an increased number of red blood cells in the blood. And then myelofibrosis can develop either after one of these two diagnoses in green or by itself. And when it develops by itself, we call it primary myelofibrosis. When it develops after one of these other two MPNs, we call it secondary myelofibrosis. And um, it's largely a nominal distinction. They're treated fairly similarly, but there might be some different characteristics of your myelofibrosis depending on whether or not you had a preceding MPN. When should you suspect an MPN? And again, I think probably many people here may have already been diagnosed with MPN or know someone with an MPN, but um, these are always kind of just a little bit of red flags, I think, for primary care doctors or in the clinic when we see someone for initial evaluation. So there are some common MPN symptoms. These, like I said before, can be things that are fairly non-specific, just, fatigue, low energy, night sweats, weight loss. And then they could be things that are more specific to, let's say, a large spleen, like stomach pain or not being able to eat a full meal like you once did. Um, there's also these kind of microvascular symptoms is the technical word for them. And the way I think about it, it's kind of these sticky blood vessels that don't kind of transport your blood as well as it normally should. And so if things get slowed down, through circulation, that can cause things like vision changes, headaches, sometimes neuropathy or numbness or tingling of the hands and feet are all possible. In terms of the blood work, if we do routine blood counts, we might catch an increase in the amount of one of your blood cells, either platelets, red blood cells, or white blood cells that might point us in the direction of one of these diagnoses. And there might also be some more nuanced changes in someone's complete blood count or CBC that might make us suspicious for some problem in the bone marrow. Um, in terms of blood work or kind of what we need to make a diagnosis of an MPN, I tried to kind of highlight, what I think are the four kind of required parts of a diagnosis, and they kind of encompass all different parts of what we do in clinic. So one of them is just routine blood work, and honestly, this is really as important to the diagnosis as some of these more sophisticated or kind of advanced testing. So a CBC, a complete blood count, is really critical and is often, the first kind of key clue that someone has an MPN. So we might see, like I said, elevated red blood cells, elevated platelets, changes in the white blood cell composition. And there's other blood tests that are important too for kind of making the diagnoses. These include things like hormonal level, something called the erythropoietin level, um, as well as some other markers that we use to kind of distinguish between the MPNs. Bone marrow biopsy is, for me, recommended at diagnosis for all my patients who I suspect of having an MPN. I think it's critical to evaluate for any bone marrow scarring at diagnosis to kind of confirm the diagnosis. And there are some nuances between all these subtypes of MPNs, ET, PV, or myelofibrosis that you can really best distinguish on the bone marrow biopsy. Genetic testing is also key to the diagnosis, right? To make the diagnosis, this is included in our standard diagnostic criteria. We need to kind of establish that there's a mutation that has led to this cancer. For 80 to 90% of people, um, uh, especially in those people with ET or MF, that mutation will be in either JAK2, CalR, or MPL. Those are what we call the kind of three classic MPN driver mutations. JAK2 is the most common, but a large proportion of people have a CalR MPL mutation as well. I think it's really important to take away from this that it's 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 necessary to go beyond just looking for those three mutations. So, maybe 10 or 20 years ago, having a JAK2 mutation would suffice in terms of genetic workup. But nowadays, we really know that many other genes, not just these three, can play a role in either prognostication or diagnosis. And and it's important to get a good comprehensive genetic evaluation when you're diagnosed. And then lastly, the spleen should be measured either through a kind of palpation, so by physical exam at your diagnosis, um, or by some imaging tests like an ultrasound or CAT scan. And having a good baseline symptom assessment is important too to know kind of where we're starting at and get a good sense of how the MPN is affecting your quality of life and your daily living. This is kind of too busy a slide, but just to kind of point out that there's other causes for red blood cells, platelets, or white blood cell changes, and especially before your diagnosis is established, it can be helpful to make sure that these other causes are being ruled out by your doctor. Helpful questions of diagnosis. So, like I said, I think it's important that you make sure that comprehensive genetic testing is done. That means looking for things besides just JAK2, CALR, MPL, as these can really affect how your MPN is treated. It's also important to know that your oncologist has treated MPNs before and is comfortable treating your MPN, and it's sometimes helpful to see an MPN specialist, even for a initial evaluation. I think can never hurt and can help kind of just broaden your MPN team. Um, and then I think I'll leave this since I'm kind of short on time, but there's some specific ways that your treatment might go depending on your goals and the specific characteristics of your MPN, whether or not it's ET, PV, or MF, and I'll let some of my colleagues talk about that in the coming talks. Very quickly, when we're talking about monitoring MPNs, I think it's a very highly individualized kind of tailored approach for each specific person. So I just tried to list some of the kind of variables here, but it's an exhaustive list, and I think depending on your type of MPN, how advanced or not advanced it is, meaning how prominent your symptoms are, how big your spleen is, how kind of abnormal blood counts are, can all kind of help frame your individualized monitoring plan. And in addition to that, treatments, side effects of treatments, monitoring for side effects, all of those are really important to take into account. But in general, the goals for monitoring are to kind of reduce or manage complications from the MPN, to improve your quality of life and symptoms, and then to monitor for and potentially reduce the risk of progression, whether that's progressing to myelofibrosis if you have ET or PV, or progressing to leukemia if you have either of the three MPNs, but especially in myelofibrosis. And monitoring includes kind of, somewhat regular blood count checks, looking for things like, for in this example, an uncontrolled hematocrit, right? A kind of an unsafe increase in the red blood cell count, but looking for things on, let's say the differential, which is down here. So the types of white blood cells there, are those changing? Are those more concerning? And again, I think the frequency of this, the frequency of symptom checks, and the frequency of spleen checks and bone marrow biopsies even are all kind of dependent on your situation and the plan that you and your MPN specialist kind of devise. But all of these components go into monitoring, and they can all be helpful to make sure that you're getting the right treatment, and to make sure that your MPN is staying that that MPN that you were diagnosed with, and not kind of changing to something else. So again, I try not to get into too much specifics here. I think they'll be touched on in the later talks, but um, that was a 10,000 or maybe 100,000 foot overview of MPNs. I won't be able to stay for the group discussion at the end, but thank you again for attending, and thanks for your time, and thanks Mike and Natalie and everyone for inviting me here today.
Thank you, Dr. Coltoff. That was a really nice, sort of accessible overview of, diagnosis and monitoring. And we're sorry that you won't be able to stay till the end for our panel discussion, because I'm sure there will be more questions about some of the slides that you've presented. But thanks for spending your time with us, and we appreciate you. And that does bring me to the point that there will be a panel discussion at the end. So we're going to save our questions. Thanks, Dr. Koltoff. We're going to save our questions for the end. You can put your questions in the chat or the Q&A at the bottom of your screen, and at the very end during our panel discussion, we will share some of those questions and get answers from you directly from these MPN specialists who are joining us today. Next, we will hear from Dr. Bhave from Atrium Health, Wake Forest Baptist, who will be talking about essential thrombocythemia. And Dr. Bhave, I don't know if you are able to put your screen on, but we are here and ready for you. There she is. Thank you so much for your time today.
Yeah, thank you, Natalie. Sorry, let me just make sure. Oh,
Yep, we could see your
you're seeing my
email.
email, huh? Okay, hold on.
We won't read it, we promise.
Okay, now, are you
Great.
seeing my slides?
Yes, we could see your slides.
Okay, and you can still see my slides?
Yep, we still see
Okay,
them.
perfect. Um, so thanks a lot. My name is Rupali Bhave. I am one of the MPN folks over at Atrium Health, Wake Forest Baptist, based in Winston. And I'll be talking to you guys about essential thrombocythemia today. So like Dr. Coltoff has already pointed out, ET is one of the myeloproliferative neoplasms, which is a disease of the hematopoietic stem cells. So your hematopoietic stem cell, those are your parent cells in your bone marrow that give rise to all of your other blood cells. And also, as Dr. Koltoff already pointed out, what happens in ET, along with the other sort of two MPNs that we'll be talking about today, is that there's this constitutive activation of this pathway called the JAK-STAT pathway. And so it's sort of stuck in this on position, which as a result kind of leads to this hypersensitivity of your parent cells or your hematopoietic stem cells to growth factors and cytokines that then leads to overproduction of blood cells. And in the case of ET, leads to specifically overproduction of your platelets that then can lead to bleeding and blood clotting complications. How common is ET? It's not super common. Annual incidence of about 1.6 cases per 100,000 people. Median age at presentation is 59, but about 15% of our patients can be quite young and diagnosed at an age of less than 40. Also, as Dr. Koltoff has already pointed out, the vast majority of our MPN patients, including ET patients, will have one of three driver mutations, the most common of which is the JAK2 V617F mutation. The next most common of which is a mutation in a gene called calreticulin or CalR, and the least commonly mutated gene in our ET patient population is a mutation in a gene called MIPL. Actually, 10 to 15% of our patients can be negative for one of these three driver mutations. And interestingly, kind of which one of these mutations or what our patient's mutational status is at the time of presentation can play a role in kind of the signs and symptoms with which our patients present. So what are some of those signs and symptoms? Again, Dr. Koltoff has gone over a lot of this, but specifically in ET, actually about half of our patients can be asymptomatic, and perhaps patients are picked up by a primary care physician who may just happen to do a CBC or a complete blood count at the time of an annual physical. However, our other half of patients can present with symptoms such as microvascular disturbances. Again, as Dr. Koltoff pointed out, some of these symptoms can include things like headaches, lightheadedness, blurred vision, palpitations, chest pain, erythromelalgia, which is sort of this sort of warmth, pain, and redness that some of our patients can experience in their distal extremities, or burning pain in the toes or fingers. About 15 or 13% of our ET patients can present with a big spleen. ET is not the patient population of MPN folks who usually present with a big spleen, but again, a minority can, and if the spleen is big enough, then patients can have symptoms related to their enlarged spleen in the form of belly pain or sort of feeling full very quickly after they eat a meal. What are some of the signs that our patients with ET can present with? So, a portion of our patients can present at the time of diagnosis, or have a history prior to coming to sort of a diagnosis with a blood clot in an artery or vein. So, 14% of patients will have a blood clot in an artery at or prior to diagnosis of their ET, and 10% of patients will have a blood clot in a vein at or prior to the time of their ET diagnosis. And sometimes these blood clots can be in unusual places, like the splanchnic vein. So the splanchnic vein is kind of your abdominal vein system that brings blood lacking oxygen from the abdomen to the hepatic vein, and then to the inferior vena cava, and then to the right atrium. Another sort of less common or unusual place that our patients with ET can clot is in the cerebral vein, or sort of the brain's blood draining system. Interestingly, though our patients present with high platelets, patients with ET can also present with or have a history of major bleeding. So about 8% of patients with ET can present with major bleeding at or prior to diagnosis. Usually patients with ET have a normal hemoglobin. Usually patients with TT have a normal white blood cell count, though some can present with a high white blood cell count. And generally speaking, the kind of median platelet count at time of diagnosis of ET is about 700,000, with about a quarter of our patients presenting with a really, really high white blood cell count. How do we diagnose ET? So we have these sort of criteria that you have to fulfill. And I wanted to point out a couple of things. Part of this diagnostic criteria includes making sure that you don't have an elevated platelet count for a non-bone marrow biopsy or bone marrow diagnosis reason. And then the other thing to point out is that there are actually quite a few different bone marrow disorders that can present with an elevated platelet count. So it's really critical that you kind of are making sure to rule out both reactive non-bone marrow disorder causes of an elevated platelet count when a patient comes to kind of presentation, and that we're making sure that if a patient does have a bone marrow disorder, that it's ET and not one of this sort of very long list of actual bone marrow disorders that can again present with an elevated platelet count. And Dr. Coltoff kind of went over had a slide about some of the reasons for non-bone marrow disorder, kind of causes of an elevated platelet count. Those things include things like iron deficiency, blood loss, surgery or trauma, inflammation or infection, and even other kinds of solid tumors can present with an elevated platelet count. So really, in order to make a proper diagnosis, like Dr. Coltoff pointed out, for all MPNs, including ET, you really do want to do a bone marrow biopsy. It's really important to distinguish ET from some of these other non-ET bone marrow disorders that can present with exactly the same thing. A lot of you folks on the call have probably already had a bone marrow biopsy, but remember, the way we do it is at the back of our kind of posterior iliac crest, we have a ridge that is or our posterior iliac crest rather, is very close to the surface of our skin. And we can kind of, when patients are lying on their belly, we can kind of feel exactly where that ridge is. And that's where we go to get a small specimen. And typically we do this right here in clinic. So when someone is diagnosed with ET, what are really the consequences of having this diagnosis? Well, broadly speaking, first of all, in terms of prognosis, the overall survival is really very good. Median overall survival is about 20 years, and it's even longer for our younger patients. But in comparison to patients of the same age and sex, the overall survival is a little bit inferior. The vast majority of ET patients luckily won't transform to acute myeloid leukemia, but there is a less than 5% chance that that could happen over a patient's lifetime. And then there is also a less than 10% chance that a patient with ET could transform over their lifetime to the scarring bone marrow cancer called myelofibrosis, which Dr. Mesa will talk about later in this program. And then finally, kind of the biggest issue with a patient having ET is the risk for blood clotting or thrombosis, and that can happen in anywhere from 10 to 25% of our patient population. But not every patient with ET is at the same risk for blood clotting. The way we decide whether a patient is at very low, low, intermediate, or high risk for blood clotting is based upon their age, whether or not what kind of driver mutation you have. So, of those three driver mutations, the one that is associated with the highest risk of blood clotting is the JAK2 mutation. And then whether or not you've had a blood clot in the past will play a role in how high a risk you are for having another blood clot. If you've had a blood clot in the past, your risk for having another one in the context of having ET is quite high. One of the things that I wanted to point out is that there is no correlation between the degree of platelet count elevation and thrombosis. We really want to be mindful that when we're sort of talking about how we're managing patients, that we really decide whether or not to put someone on a platelet lowering agent based upon sort of not just their total platelet count, but other factors that we'll go into. So what are the goals of treatment in ET? So number one, the one thing that we always just need to be sort of remind ourselves about is that interestingly, all MPN patients are at slightly higher risk for other cancers. So we don't go crazy in terms of screening for other cancers, but we want to make sure that our patients are getting age-appropriate cancer screening. Mammograms are on time, colonoscopies are on time, and if they demonstrate any other sort of signs or symptoms that are worrisome, then that we not kind of poo-poo it, if someone's having some black tarry stools or bright red blood, that again, we just sort of pay attention to those, potential signs or symptoms of other cancers. One of the big goals of treatment in ET is to prevent blood clotting. We talked about, again, every patient with ET is at some risk of blood clotting, but not everybody is at the same risk of blood clotting. In going along with this, one of the things that's important in preventing clotting is to control your other cardiovascular risk factors. So really important to have a good relationship with a good primary care doctor to make sure your other cardiovascular risk factors that can put you at risk for heart attack and stroke, like hypertension, high cholesterol, diabetes, are all under really, really good control. If you're smoking, stop smoking, good diet and exercise. And then the other things that we consider when we're trying to decide how to reduce our patient's blood clotting risk is whether or not we need to put someone on what we call a cytoreductive agent, which is a platelet lowering agent, or an antiplatelet agent, which when we're talking about that, we're talking about aspirin. We also want to prevent bleeding complications. And again, when we're thinking about how to do this, we're thinking about whether or not we need to put patients on a platelet lowering agent or on aspirin, or whether it's, safe to put someone on an aspirin. And we'll talk about that in a minute. And then a lot of our patients, like I said, do present with symptoms. So if we have a patient who's symptomatic from the ET, we want to control their symptoms. And then in a perfect world, we want to eliminate, ideally, the risk of our ET patients progressing to myelofibrosis or acute leukemia. And we ideally would love to completely normalize overall survival. So when we're thinking about who to put on an antiplatelet agent in the form of aspirin, in this context of our ET patient, really what we're thinking about is, do we need to put a patient with ET on aspirin in order to reduce the blood clotting risk? Again, when we're thinking about that, we really want to be mindful about how high or not our individual ET patient is for blood clotting. So when we're thinking about our ET patients, if they end up finding themselves in what's called this revised IPSET thrombosis risk score, so a very low risk for blood clotting, interestingly, that patient's blood clotting risk is really not that much higher than the average patient population. So typically we don't put patients on an aspirin if they find themselves in this sort of very low risk for blood clotting category. The only reason that we would do it is if our patients have these microvascular symptoms. Aspirin can be very helpful in helping to improve or eliminate those microvascular symptoms like headache or erythromelalgia. In all of our other kind of risk categories for blood clotting, low, intermediate, or high, we typically all put our patients on an aspirin. There are a couple of caveats, and so A couple of things to keep in mind is that a portion of our patients with ET will have what we call extreme thrombocytosis, which is just sort of generically defined as a platelet count of over 1,000 or 1,000,000. And what we need to be wary of is that every once in a while in this setting, patients with ET will have what's called acquired von Willebrand syndrome. And what the von Willebrand is, it's this protein that basically works with platelets together to stop bleeding. And sometimes when the platelet count becomes very high, this protein gets broken down faster than the body can replenish it. And in that context, your risk of bleeding is very high, especially in the presence of aspirin. So if this is going on in our patient, we want to temporarily hold aspirin if they're on aspirin. And the way to resolve this issue is just to lower the platelet count. And you don't necessarily need to normalize it. You just need to get it a little bit lower with a platelet lowering agent. And then this acquired von Willebrand syndrome resolves. The other thing to keep in mind is that there's some mixed data in our patients with ET who have particularly a calreticulin mutation, where those folks are actually at the lowest risk for blood clotting and are at slightly higher risk for bleeding. So there's some debate whether or not we should really be putting our patients with calreticulin mutated ET on aspirin or not. And that's just a discussion to have with your MPN provider. So then moving on to cytoreductive agents or platelet lowering agents. Again, why do we think about putting our patients on a platelet lowering agent? We're thinking about it when we feel like we need it to reduce the risk of blood clotting or to reduce the risk of bleeding. And then also, it can also be useful in controlling symptoms. What are the agents available to us? They include things like some of the things you guys may already be on: Hydrea, anagrelide, ruxolitinib, and interferon. And again, not every ET patient needs to be on a platelet lowering agent. So when we're thinking about which sort of category of patients to put on platelet lowering agents, we typically think about putting our patients who are at highest risk for blood clotting, putting those ET patients on a platelet lowering agent. And we sometimes think about it in our patients who have lower risk disease but have kind of bothersome symptoms, because again, sometimes these platelet lowering agents can be helpful in managing symptoms. When we are putting our patients on a platelet lowering agent, is there kind of a goal platelet count that we're trying to achieve? So interestingly, we have all these kind of response criteria, but interestingly, achieving kind of perfect platelets has not necessarily been directly correlated with reducing blood clotting risk or bleeding risk. So really the optimal platelet goal is not established. More or less, we try to normalize the platelet count, but we try not to do it at the sacrifice of side effects. So again, just very quickly going through our platelet lowering agents or our cytoreductive treatment options that we have available to us right now in ET. Hydrea is one of the oldest ones. It's an oral chemo pill. There is data to show that it will decrease blood clotting events. Some of the side effects that our patients can experience with Hydrea include oral ulcers, skin ulcers, sometimes very rarely fevers, anemia. There is a risk of non-melanoma skin cancers in our patients with Hydrea. So I like to have my patients on Hydrea, just touch base with a dermatologist once a year to get a good head-to-toe skin exam. And then for our younger patients, Hydrea is teratogenic. So we don't really want to put our patients who are of childbearing age on Hydrea because it will cause birth defects. Another cytoreductive or platelet lowering agent that we have at our hands or on hand for our ET patients is anagrelide. It's not really a chemo agent. It kind of causes a dose-related reduction in platelet production. It affects platelet maturation. There is data that it can work just as well as Hydrea in decreasing risk of blood clotting and bleeding. It also does have a side effect profile that is sort of a little bit more problematic, I would say. A lot of times it can cause dizziness and palpitations, some fluid retention. There is also some data to show that it increases risk of progression to myelofibrosis. Not an agent that I think a lot of us use a ton anymore, but sometimes it is still something that a minority of our patients can be on. It is, again, also teratogenic, so don't want the patients who are of childbearing age on it. Ruxolitinib is actually not FDA approved for ET. It is an oral JAK inhibitor that's approved for PV and MF, but there is data in ET that it can be just as good as some of our other drugs in reducing blood clotting risk. But I would say the benefit that ruxolitinib or Jakafi provides in our ET patient population is in the context of symptom control. I think all of us have, some patients who are having a hard time with symptoms that are not being well controlled on maybe some of our other platelet lowering agents, and sometimes either alternatively being on Jakafi or sometimes even in addition being on Jakafi can be very helpful. It is mutation agnostic, so even though it's a JAK inhibitor, it works regardless of what mutation you do or don't have. And then some of the side effects that we see with Jakafi include anemia, diarrhea, weight gain, and then increased risk of opportunistic infections and viral reactivation. And then finally, one of the last agents that we have at our fingertips for platelet reduction or cytoreductive treatment option in ET is interferon. Interferons have been around forever. They're a group of cytokines with these immunomodulatory properties, and they were the first immune therapies used in cancers, including in hematologic cancers. Some of the early non-pegylated forms of interferon were really difficult to tolerate, but now what we have on hand to use are these pegylated formulations, which have longer half-lives. They don't need to be dosed as often, and they're much better tolerated. And the two that maybe some of you guys are on already, but that are available for use now include pegylated interferon alpha 2A, also known as Pegasus, and rho-pegylated interferon alpha 2B, also known as Besremi. Now, even these longer-acting formulations have some side effects, including flu-like symptoms, lowering of the white blood cell count, liver enzyme abnormalities, and a little bit of increased risk for developing autoimmune disease and some small risk of causing depression. But overall, these pegylated interferons are really well tolerated. There have been a number of trials in ET that have shown really nice response rates with interferons over the last 3 decades, and a number of recent studies have shown the same, both in patients who have never been on a platelet-lowering agent before and patients with ET who have been on other platelet-lowering agents and either haven't tolerated or have had disease progression through it. And basically, big picture, their interferons are effective in normalizing blood counts without bleeding or clotting events. But more importantly, there's this question about whether or not interferons may actually change the biology of the disease in MPNs, including in ET in particular. So there's some data to show that sort of how much of a driver mutation or variant allele frequency you have in your abnormal cells can be correlated or has been correlated with how severe your disease is, how bad your blood counts are, how bad your symptoms are, how bad your spleen is, what your risk of blood clotting is, and also what your risk of progressing to a worse MPN is, or even transforming to AML. And we know that a lot of our platelet-lowering agents can reduce this variant allele frequency or how much of this driver mutation you have. But interferon in particular seems to result in deeper reductions in VAF or variant allele frequency as you're on drug for longer periods of time. So it seems reasonable to hope that reducing VAF will have a positive impact on long-term outcomes and disease course. So is it possible that interferon can change the biology of disease in ET so that we're reducing or eliminating progression to myelofibrosis or acute leukemia, and can it possibly normalize overall survival? Interestingly, there's been some data in ET and other MPNs where interferon has resulted in kind of these treatment-free remissions. There was a kind of a retrospective look at an institution in Paris where they looked at over 300 patients, half of whom had ET, who had been on interferon, had come off for some reason, and then they kind of followed these patients. And what they found that a lot of these patients were able to continue with normal blood counts for a prolonged period of time. And then also importantly, if after a period of time off treatment, the blood counts became abnormal again, those patients could have their interferon reintroduced and they would have normalization of their blood counts again. So again, it's sort of a nice um, a nice signal again that interferon may be kind of changing the biology of the disease in a positive manner. Um, and then finally, so that's kind of what we have at our fingertips right now. Lots of novel therapies in ET that are under investigation. You guys may have heard of one in particular for which there's quite a bit of data called bomedemstat. I know I'm over time, so I'll just quickly go over that this is an oral drug. It inhibits this enzyme called LSD1, which is an enzyme that regulates growth and maturation of progenitor cells, including your megakaryocytes, which are your baby platelets in your bone marrow. There's been good phase 2 trial data that has come out that shows that it can normalize platelet counts and it can also decrease the VAF. And there are 2 big phase 3 randomized trials, both in patients who have never been on a platelet lowering agent and in patients who have been on a platelet lowering agent before, both of which are now close to accrual. So we look forward to kind of hearing what the results of those 2 trials are. And then the other one, that other agent that you guys may have heard of already is this sort of monoclonal antibody specifically directed at patients who have a mutant CALR. Um, and its name is INCA033989. Again, it is a monoclonal antibody that particularly targets this mutant CALR, which is only expressed on your abnormal, cells and not on your normal cells. And so it's kind of this attractive target. And there are 2 large multi-center phase 1 studies ongoing in ET, both in the US and outside the US. And in the bit of readout that we've gotten from those trials so far, this monoclonal antibody to mutant CALR is really well tolerated. It's shown to provide normalization of blood counts without bleeding or clotting, and it also has been shown to reduce driver mutation variant allele frequency. And then also interestingly, it's been shown at the level of the marrow to reduce the total number of megakaryocytes, and in particular to reduce the total number of mutant CALR megakaryocytes. These trials are still ongoing. It's an IV medication as it was first trialed that is administered every 2 weeks, but they're studying a subcutaneous dosing and randomized phase 3 trials are in the process of being developed and opened. And again, there are other new drugs in ET in the pipeline rather. I'll stop there. I'm sorry I'm over my time, but happy to take questions at the end.
Thank you so much. I really appreciated that. I know that the people watching also appreciated that in-depth sort of deep dive into essential thrombocythemia. And as you were speaking, we were getting several questions. So I know that if you're planning to stay with us until the end in that panel discussion, that we'll be happy to share some questions that we got on your slides today.
Yeah, happy to.
Thank you so much. So next, we are going to hear from Dr. Lindsay Rein from Duke Health. And no, I'm sorry. I'm wrong about that, everybody. Backing it up. I made a mistake. We are actually going to hear from Dr. Brandi Reeves. So sorry, but nice to see you, Lindsay. So Dr. Brandi Reeves from UNC School of Medicine, who is going to share with us some information about polycythemia vera. It's nice to see you, Dr. Reeves.
Likewise. Thank you for having me. Let's see.
Thanks for
Okay,
taking your time. Okay, we can see your slides.
perfect. All right. Welcome, everyone. My topic today is polycythemia vera, and I thought I would approach this not by pretending that you're medical students, but more by approaching this with questions I get commonly asked in clinic. So here are my disclosures. These are my slides. They weren't influenced by anyone, but nevertheless, I have done some consulting work and serve on the scientific committee for a couple of studies. And I like to introduce my talks to patients with this slide, which is my team. And this is mostly to highlight that while MPN is considered rare, especially in community practice, at academic institutions, there is typically a whole team dedicated to rare diseases. And so for us, we have 3 clinicians and we're hiring a fourth. We have a clinical pharmacist, a nurse navigator. We have 2 new patient intake coordinators. We see over 700 MPN patients, and that grows by about 100 new patients every year. So going to a specialized MPN center really can make a big difference in your MPN care. My goal for this about 10-minute talk is to really answer the questions that I hear most often from people living with PV. And that is, what is it? What should I worry about? What can we do about it? And then what can I do? And so we only have 10 minutes, so many important topics are not included here. So my little disclosure. So topic 1, what is polycythemia vera, or PV for short? So it's funny, Dr. Coltoff and I apparently like the same analogy when we're talking about JAK2. So I think about this as being a gas pedal with a foot. And so normal cells, normal blood cells, actually have receptors on their surface that sense signals from your body that say, hey, I need more blood cells, or I have plenty. And so one of the signals that is sent is something called EPO, or erythropoietin. And if that finds the right gas pedal or receptor, it puts the foot to the pedal, and that stimulates a signal in something called JAK2. And so the gas is flowing, the car accelerates. You don't have acceleration or blood cell production when you don't have the signal. And this is responsible for the production of red blood cells, white blood cells, and platelets. In polycythemia vera, though, just by random chance, you can get something called a JAK2 V617F mutation. And this is an activating mutation. So you don't no longer need the foot to be on the pedal to have the pedal stuck and the gas down and the accelerator on. So without your body asking, you're producing too many red blood cells. You can also make too many white blood cells and too many platelets. And so, because this is an acquired mutation where you're making too many cells, it is classified as a blood cancer. It is not an acute leukemia. It's what we call a chronic blood cancer, meaning that it's slow growing, but it can lead to serious complications over time. So then why did I develop polycythemia vera? Well, the answer is most of the time by random chance. So this is not a mutation that you're born with, but generally one that is acquired. Most often, it appears to be acquired by the second decade of life, and it stays quiet for a long time until at some point, usually around the age of 60, your blood counts increase and somebody recognizes this on a routine blood test, or maybe you're having some symptoms. While this usually occurs by random chance, there are some associations, they're fairly weak, about things that have been implicated in increasing the likelihood of developing an MPN. And those things are benzene exposure, radiation, so like Hiroshima, the atomic bomb in that area, smoking, obesity, and there's some data to suggest that Agent Orange is also associated with MPNs, certainly with myeloid malignancies in general. So because this is not inherited, you generally are not passing it on to children, but it is important to recognize that you can pass on an increased risk of developing an MPN to your children. There's also an increased risk in your first-degree relatives, like your siblings and your parents. So that increase is about 5 to 7-fold increased over the general population, which sounds fairly substantial, but when you consider the rarity of polycythemia vera, which is roughly 1 in 50,000, that increased risk actually doesn't equate to a whole lot. And so it's still pretty rare in children and first-degree relatives. Okay. And so then what should I worry about with polycythemia vera? So the big thing that we think about with PV is that there is reduced survival. And here you can see that the blue line is the expected survival in the general population, and in PV is red. And this is age match control. So if you're controlling for age and gender, there is a decreased survival in patients with polycythemia vera, but the survival is still generally measured in decades. So here, this was in 2014, the estimated survival was about 14 years. It should be noted, however, that age is a very big driver of survival, and many patients with PV are actually over the age of 60 at diagnosis. So obviously, the older you are, the less overall survival you have. If you're diagnosed young, you can have 30 and 40 years of anticipated overall survival with polycythemia vera. Mutations, so co-mutations, can also be important along with white blood cell count and then lymphocyte counts, and we'll see that in the next slide. The main cause of reduced survival in polycythemia vera are blood clots. So about a third of patients with PV die from a blood clot, and that could be a blood clot in the heart, so heart attacks, strokes. They can be blood clots in the legs. Those generally don't kill you, but then they can travel to the lungs as a pulmonary embolism, and those can be fatal. As you heard from Dr. Bhave, you can also get weird clots, so venous clots, not arterial clots, in the brain as well, and then weird blood clots in the belly. And so the about 20% of patients with PV will present with a blood clot at or just before their PV diagnosis, but that risk remains elevated throughout the diagnosis. So about 1 in 5 will have a clot even after PV is diagnosed. The other reason that we care about PV is that patients can be very symptomatic. So while roughly half of patients are asymptomatic at diagnosis now, you can see that many patients with PV do experience fatigue, and some actually have moderate to severe fatigue that can really impact quality of life. Early satiety, so feeling full after just a few bites of food from a big spleen, can happen. You can feel tired, so you might be inactive. There can be itching. So for many, it's mild, but for some patients, that can be really severe, and that's often after a warm shower or bath. Sometimes even with swimming in a pool, we've had patients who don't want to go swimming because they itch so badly. And then can manifest with things like concentration difficulty. So short-term memory and then paying attention, almost like ADD, can happen in our patients as well. And then, as you heard from Dr. Coltoff and Dr. Bhave, this is not a static disease. This is a disease that can change over time. So this can progress to myelofibrosis at a rate of about 1% per year, and a feared complication is acute myeloid leukemia at a rate of about 0.5% per year. So these things should not really keep you awake at night. So we're thinking about those long term, but the more imminent threat to health is the thrombotic risk in polycythemia vera. Okay, so then you've also heard lots of arguments about having a bone marrow biopsy and other molecular testing. So yes, I do think it's generally a good idea to have additional molecular testing, so either from the bloodstream or from a bone marrow biopsy. But I will say it's not absolutely necessary for management. So we can get the JAK2 test from the peripheral blood. We can see that your hemoglobin hematocrit are sky high. This waddles like a duck. It quacks like a duck. This is a duck. It's very unlikely that it's going to be a swan, right? So if I'm in a low resource area, a bone marrow biopsy is very difficult to get. It's really costly for these additional tests. Then we can operate under the assumption that this is polycythemia vera to start, and then kind of go through things as time goes on, depending on how the clinical course goes. It's still a great idea, though, to have a bone marrow biopsy up front and the additional molecular testing because it does give us additional prognostic data. So the two big kind of overall survival calculators that we're now using in polycythemia vera are this MIPS PV and this AAA score. And I just put them up here so you would have some idea of what it is we're looking at. Because if you Google overall survival in PV, it's going to say, right, it's reduced somewhere on the order of 10 years, and you're going to freak yourself out. But look here, for some patients, the median overall survival is upwards of 25 years. And for some, it's really reduced. In this scoring system, it was 3 years if you had really high risk disease. So again, another reason I think it's important to see an MPN specialist to really understand what your risks are with this disease up front. So then what can we do about it? So we know we have it, what can we do? So our National Comprehensive Cancer Network guidelines suggest that because thrombotic risks are the most eminent to your health and longevity with PV, that we think about managing PV based on your risk of thrombosis. And currently, the way that is broken down is by age and whether or not you've had a blood clot. So, low thrombotic risk is considered less than age 60 and no history of thrombosis. And in those patients, there's roughly a 3% chance per year of getting a blood clot. High thrombotic risk is either you're 60 or older and or you've had a blood clot. And in those patients, the risk of a blood clot is about 5 to 11% per year. For all patients, regardless of risk, we want to manage cardiovascular risk factors, so blood pressure control, weight management, diabetes, lipids. Everyone generally is going to get a low dose aspirin, 81 milligrams once a day, because that's been shown to reduce the risk of clotting in polycythemia vera. And for everyone, we'd like to maintain a hematocrit of less than 45%. And often that's with supplemental therapeutic phlebotomy. For low thrombotic risk patients, the guidelines suggest that the preferred regimens are a clinical trial or Ro-PEG interferon. And then other recommended therapies would be hydroxyurea or PEG interferon. And for high thrombotic risk, the preferred regimens are hydroxyurea or Ro-PEG interferon, and other recommended are PEG interferon or ruxolitinib in certain circumstances. And so one of the questions I get asked is, do I really need to keep my hematocrit less than 45%? Is 47% awfully close to 45%? And the answer is yes, you do. So there was actually a randomized controlled trial evaluating lower versus higher hematocrit targets in PV. So this was 365 patients that were randomized to keep their hematocrit less than 45% or 45 to 50%. And the primary endpoint in the study was the time until a cardiovascular death or a major thrombotic event. They actually stopped the study early because there were 4 times more events in those who were maintaining hematocrit 45 to 50% versus less than 45%. So that is why your MPN doc is always harping on this hematocrit of less than 45%. Okay. And then I think it's also important to understand here. So you didn't hear about anything. These therapies are not curative. The therapies that we currently have for polycythemia vera are reducing the number of cells and sometimes targeting the abnormal stem cell. The only curative option that we have in PV at this time is hematopoietic stem cell transplant, which carries a roughly 20% risk of mortality in the first year. That is not acceptable in a disease that has a decade plus of anticipated overall survival. So when we think about then what our therapies are doing, I think it's really helpful to think about what the mutation is causing. So the mutation, as we saw, is causing not only the increase in cell counts because of that JAK activation, but it also turns out that JAK is important in other aspects of the cells, and it changes how those cells work. So for instance, white blood cells, which normally spit out this sticky stuff to trap bacteria, spit it out more readily and easily when you have a JAK mutation. And that sticky stuff can catch platelets and lead to increased blood clotting. We also know that in the bone marrow, the abnormal cells release factors that cause scarring in the bone marrow, which we call fibrosis. It lets these cells out into the bloodstream that then get lodged into the spleen and cause the big spleen. And these inflammatory signals also cause many of the symptoms that patients experience, as well as clonal instability, which can lead to new mutations and the development of myelofibrosis and acute leukemia. So when we're thinking about the therapies that we have 2 types of interferons. The one that's FDA approved for PV is the Ro-PEG interferon, which the brand name is Besremi. It's a subcutaneous injection that you give yourself, usually about every 2 weeks. Pretty costly, and these are from ChatGPT, I must say, but I think this is the wholesale cost, and it's variable depending on your insurance, what the actual cost is. Most patients, however, get this covered for usually under $50 a month. This has a host of adverse events that you heard from Dr. Bhave. And one of the big things with the interferons, like she was saying, is that you can target those abnormal stem cells and reduce the number of cells that are carrying that JAK2 mutation. In Polycythemia vera, that's actually been shown in a prospective study, so the PROUD and continuation PV study, to be associated with fewer thrombotic events, less progression to myelofibrosis, less progression to acute leukemia and death. Then we have hydroxyurea, which has been a standby drug for more than 4 decades now. It is not FDA approved for PV, but it is guideline endorsed. It's oral, it's relatively inexpensive, it's pretty well tolerated overall. It doesn't really target the abnormal stem cell clone in the long term. Then we have ruxolitinib, which is also Jakafi. It is FDA approved for second line after hydroxyurea. It is oral as well. It's relatively expensive. It's also relatively well tolerated, I will say, with the exception of weight gain in polycythemia vera. It does look to be able to reduce the mutant allele burden and potentially have disease-modifying capabilities very similar to Ropeg interferon. And then, of course, there's the old standby therapeutic phlebotomy, which is usually pretty cheap, maybe not super fast. So even though it seems like donating a pint of blood would be quick, the inefficiencies of clinic can make this actually a couple-hour event. It can cause iron deficiency, and for many patients can make them more tired over time. It has no effect on the allele burden. And then coming soon, we think, are going to be iron rebalancing therapies. And the one that is up for consideration by the FDA right now is called rusfertide. And I think the big thing for patients in thinking about rusfertide is this not only controls the hemoglobin hematocrit, but has the potential to improve fatigue and maybe the MPN symptoms as well. All right. And then finally, what can I do about PV? Well, so we know that maintaining a healthy lifestyle is important. Stopping smoking is probably one of the biggest things that you could do, controlling your blood pressure, cholesterol, and blood sugar. There's not been any particular diet that's proven effective in managing PV. There is an ongoing study of the Mediterranean diet with Dr. Fleischman at UC Irvine, but I haven't seen any data from that yet. There haven't been any particular supplements also proven effective. We've seen N-acetylcysteine, and there's some red algae, and no large randomized studies on that. I would caution you with iron supplementation without your hematologist supervision, though, because if you give iron to red blood cells, they're going to make more, and so you're going to drive your hematocrit up. Weight management is becoming intriguingly interesting. And this with the GLP-1 agonist, so the weight loss drugs that people are using now, there's some preliminary data suggesting that there is less progression with polycythemia vera in patients who are taking these types of medicines. It's not clear if that's just because of weight loss or because the action of the drug, so to be determined there. And then I think very excitingly, we now have some data showing that exercise can be useful in MPN. So this MPN Fit study, which you see here. So this was a study that they looked at a home-based exercise prescription. And what they found was that physical activity in this way actually improved patients' quality of life across MPNs. And that's the first data, to my knowledge, that shows that an exercise program in MPNs can actually improve quality of life. And so I think it's really important for patients to consider measures that you can do for yourself as well. And with that, I'm going to summarize these 5 key points. So PV is a chronic blood cancer. Most live with it for many years. So what we do today, we have to be thinking about has the impact 10 years from now. Preventing blood clots is still our most important goal in PV. Maintaining the hematocrit of less than 45% is important, but increasingly, we're also targeting getting rid of the mutant blood stem cells. And then PV treatment is individualized, and seeing an MPN expert early in your PV journey can be very useful. And there are lifestyle changes you can make to help with PV, including exercise. And with that, I thank you very much.
Thank you so much, Dr. Reeves. That was amazing. And I just want to say again, thank you to the specialists who are with us for making this information so accessible. Because while I know that many of us watching today have done lots of research and know lots about MPNs, having this language and these slides that are so accessible and helping us to understand better the mechanisms and what to expect, it's just invaluable. So we're glad that we can host programs like this. Next up is now we have Dr. Lindsay Rein from Duke Health, who is going to share with us about mastocytosis.
All
So
right. Let's
thank
see
you,
if I
Dr. Rein.
can. All right. Can you see my slides, hopefully?
Yes, we can see your slides.
Got it? Okay. So we are going to mix it up a little bit today and talk a little bit about mastocytosis or systemic mastocytosis. So a little bit of a different disorder and something that I see a lot and talk a lot about recently. So we're going to talk a little bit about it. So these are my disclosures listed here. And so systemic mastocytosis is something that has become near and dear to my heart and a large part of my clinical practice. So a little bit of a non-classic MPN, but still important to think about. So this is again a rare hematologic disorder, and this time really characterized by neoplastic and clonal expansion of mast cells. So these are cells that accumulate in various tissues, and again, mutation driven by pathogenic mutations in what we call the KIT receptor. And so the most common mutation we see in this particular group of disorders is a KIT D816V mutation, which is a gain of function mutation that causes overactivation of mast cells. And mast cells, as you can see there, typically respond to environmental stimuli. These can be anything like allergens or irritants, and they release their contents. And I'll show you another slide in a minute. And their contents are listed there. So there are things like histamines, tryptase, heparins, and various cytokines that cause a lot of allergy type symptoms. And so when the contents of mast cells get released, people tend to get a lot of symptoms. And again, systemic mastocytosis is typically due to KIT mutations. And you can see here that in the normal situation, KIT receptor is typically stimulated by a ligand, or the receptor needs some sort of stimulus to signal. But when it is mutant, you get independent activation of the receptor and basically uncontrolled activation. And so people have uncontrolled symptoms all the time. This is a little bit of a better diagram. So you can see here when you get mast cell activation, mast cells release their contents, and you get a whole bunch of different symptoms, which really do impact every system within the body. So you can see here, mast cell activators impact the cardiovascular system, the cutaneous system. So people will get flushing and itching and urticaria or hives. People can get involvement of the gastrointestinal tract with abdominal symptoms, reflux, nausea, vomiting. They get bone pain, neurologic or cognitive symptoms, so decreased concentration, anxiety, depression, the whole nine yards. And so really what I tell patients in clinic is that if you have a symptom, odds are it could be related to systemic mastocytosis. And so these are the types of things that we see in clinic. And so when folks come in and there is some concern for systemic mastocytosis, and this is usually based on a combination of symptoms and oftentimes elevations in different markers in the blood, and this is most commonly something that we call a serum tryptase, we need to get to a diagnosis. And so we need some sort of tissue diagnosis. And so systemic mastocytosis is a little bit different than other classical MPNs. And so I'm a hematologist. I'm biased, obviously. So I usually will tell people that they absolutely need a bone marrow biopsy for systemic masto. We can sometimes get away with either biopsies of the gastrointestinal tract or skin biopsies or bone marrow biopsies. But the key takeaway point here is that a tissue biopsy of some sort is necessary to get to a diagnosis of systemic mastocytosis. And I won't go into too much detail here other than to say that again, these are rare disorders, and it is really important, and I think key that you get the right diagnosis. And because these disorders are so rare, and because, as we just said, there's a lot of different symptoms that can be associated with these diseases, which can make the diagnosis complex. It's important oftentimes that patients get to centers where there's expertise from a perspective of pathologists and clinicians in making these diagnoses. And so, what we will typically do is get a tissue biopsy and utilize the criteria here listed on the left, as well as additional findings, which we call B and C findings, which I'm not going to go into detail about, really to come up with a diagnosis and to classify the different types of mastocytosis that patients have. Okay. And so, why is this important? Well, if we use all of those different B and C findings, so the different classifications of disease, we can subclassify patients with systemic mastocytosis into indolent and more advanced forms of disease. And that's really important because subclassification of mastocytosis impacts a lot of different things. So here you can see that the subclassification of disease really impacts patient survival. So in patients who have indolent systemic mastocytosis, or ISM, or smoldering systemic mastocytosis, so those are the two forms of indolent disease, overall life expectancy is generally the same of the general population. And so we know that prognosis here is excellent and typically not impacted. Whereas if patients are classified with more advanced forms of disease, you can see depicted there with the yellow or the green bars, prognosis is impacted and survival is impacted. And so again, this is why it's important to be seen at a specialized center and really by an expert. So you make sure that the diagnosis is correct, the subclassification is correct. And so you really know what you have and what you're dealing with. I will say as well that subclassification also impacts treatment. Okay, so subclassification we know impacts the diagnosis, it impacts prognosis. It also typically impacts your clinical presentation. And so this is a little bit of a backwards, and this was a little bit hard to wrap my mind around when I started treating patients with SM over a decade ago now, actually. But what is interesting is we know that people with indolent systemic mastocytosis tend to have lots and lots of symptoms. So I think oftentimes, in my mind at least, it would seem that people with more advanced disease would have more symptoms, but this is actually not the case in systemic masto. So people with indolent disease tend to have more symptoms, whereas people with more advanced disease, as you can see here on the right, tend to have more evidence of organ damage. So on the left, you'll see indolent disease, people, again, lots of symptoms, lots of different presentations, whereas on the right, people with advanced disease tends to have more infiltration of mast cells into organs, and people tend to have more evidence of end organ damage. So they have organ enlargement, they have changes in blood counts, they have evidence of malabsorption and other types of things. And so again, the subclassification, without going into too much detail, again, impacts your clinical presentation. This is a really common referral that we get in clinic and something that we're seeing more and more commonly. So again, systemic mastocytosis is a rare diagnosis, but there are a lot of people who have a lot of symptoms, and it's interesting to know that true systemic mastocytosis represents really only a small portion of disorders that are associated with mast cell activation. So remember, anytime a mast cell is triggered, it releases its contents into the blood, and it can create symptoms related to those different activators that are released into the blood. And so not everybody who has symptoms has true systemic mastocytosis. And you can see this, and I put this up here just to say that there are other diagnoses like mast cell activation and monoclonal mast cells and other diagnoses that are related and similar, although not true systemic mastocytosis. And so, again, this is just another push here for really specialized care and collaborative care from a hematologist and allergists gastroenterologists, dermatologists, and then a whole care team if you are having these types of symptoms and if there's concern for mast cell disorders, because it really truly does take a village and a team to get to some of these other diagnoses. This is a busy slide, and we've been talking a lot about the diagnosis. And I mentioned before that systemic mastocytosis, the characteristic mutation is a c-KIT mutation. I put this up here just to make the point that it's really important as part of the diagnosis to make sure that you're getting the right test sent. So a really common referral that we see in clinic is patients who seem like they have systemic mastocytosis. So they have all the symptoms, they may have a bone marrow biopsy or a skin biopsy that looks, but they have a mutation panel that is sent, and they don't have a KIT mutation. And most commonly, they'll have what we call a next generation sequencing panel that's sent, and that's really not the right test. So the point to make here is that you really need a very sensitive test, oftentimes, in order to detect c-KIT mutations. And so if you look here, you can see that there's various types of tests that can be sent. And what you really want to make sure you're getting sent is something called a digital droplet PCR test. And the level of detection for this test is 0.022%. So again, people, which is actually pretty remarkable, these mutations can be present at levels that are less than 0.1% to be considered positive. And so as you're getting workups done and as people are getting these tests drawn, it's really important to make sure that you're getting the correct testing sent to get to an accurate diagnosis. All right, so I've said this before on multiple talks. I was a music history major in college, so I love a good historical perspective. I'm going to go through this pretty quickly. This is Paul Ehrlich. He won the Nobel Prize in 1879 for the discovery of mast cells, so these have been known and around for a very long time. If I think about my own historical perspective, this is a table circa 2003. This is when I was still in med school, a very long time ago. These are the treatment options for systemic masto back in the day. And if you look here, there's a whole bunch of treatments here, and I will tell you that none of these work very well. These are mainly symptom-based therapies. So these are things like antihistamines and really agents that were used to try and stabilize mast cells. None of these are targeted therapies. Many of these treatments don't do anything to alter the biology of the disease. And it made it very hard to treat patients with systemic mastocytosis. And so I show this particular timeline in a majority of my talks because I think it is incredibly phenomenal that really over the past decade, so from 2016 until 2026, there has been such incredible progress made within this field. And really, it has been such an incredible honor to be a part of the progress. So if you look even between 2020 and 2026, we have seen the development and approval of we call c-KIT inhibitors, which we'll talk a little bit about, which have truly changed the face and the management of patients with systemic mastocytosis. And I think the take-home point here is that this is incredibly quick for the development of really a novel class of therapies. And so what are c-KIT inhibitors? Well, again, if you remember what I said before, systemic mastocytosis is characterized by a c-KIT mutation. And so it would make sense that we would develop highly selective therapies to target the c-KIT mutation, and that's what we have. So tyrosine kinase inhibitors that target c-KIT. And you can see that there are two agents that are farthest along. So avapritinib is an FDA-approved agent. We'll talk a little bit about that. And then bezuclastinib is a second-generation agent, which is farthest or next farthest along in terms of approvals. These are both c-KIT specific inhibitors with specificity for the D816V mutation. And so this is a list here just of our current and future goals of therapy. And so I think as a patient, these are important things to keep in mind. So what are we trying to do as we're treating systemic masto? Well, with anything, we're trying to improve your survival and your progression-free survival and all those things. We're trying to make you feel better. We want to improve your symptoms. We want to get people on well-tolerated chronic therapies and minimize side effects. And for systemic masto in particular, we want to decrease the available biomarkers of disease, and we're going to talk a little bit about those. So mast cells, serum tryptase, and then your mutational burden. So that's c-KIT mutation. And then longer term, we want to think about some things like bone health, disease modification, and safety and tolerability. I'm going to try and get through this stuff pretty quickly, so we're not going to talk in too much detail. So this is the Pioneer study. This was actually the clinical trial that led to the approval of avapritinib. So this was the first true targeted therapy for management of patients with indolent systemic mastocytosis. And I'm only going to talk about indolent disease as part of this talk because it's only 10 minutes. So for this particular study, patients were treated with 25 milligrams of avapritinib versus placebo, and then patients had an opportunity to cross over to receive active drug if they had been treated with placebo. And what we looked at was improvements in what we call a total symptom score. And so we looked at various symptoms and calculated a total symptom score. And what this shows here is that long term, so after 4 years of data, people showed significant improvement in symptoms. And so this was when you looked at symptoms across total symptoms, and then also when you looked at individual symptoms and categories of symptoms. And so again, people felt better. And when you looked at changes in biomarkers of disease, things like the serum tryptase, and then change in mutational burden, so that KIT mutational VAF or variant allele fraction, these things decreased over time, which suggests that there's a modification of disease or change in biomarkers. And so this, again, led to the approval of the first c-KIT inhibitor, which led to, again, improvement in symptoms and biomarkers for patients with systemic mastocytosis. And I think was really a great example of the first true targeted therapy for patients with SM. We mentioned before that one of the goals is to develop safe and tolerable therapies. And I think this is a busy slide, but what it shows is that these treatments really are safe and tolerable over time. Patients do really well with these treatments. And the side effects in indolent SM tend to be pretty manageable. So peripheral edema, some headaches, some nausea, and gastrointestinal side effects are the main side effects that we see. We know that patients with systemic masto have increased risk of decreased bone health, so osteoporosis and osteopenia. That's one of the big long-term complications of disease. And what we're finding as people have been on these novel targeted therapies longer is that some of these long-term complications of disease are actually improving over time. So this is a busy slide, but what we've looked at over time is improvements in DEXA scans or bone density scans over time as people are exposed to these c-KIT inhibitors. So this is data from the Pioneer study. So this is avapritinib, what we just showed you. And what we see is that after 3 years of therapy, patients are experiencing improvements in their overall bone health. So that's pretty exciting to see that we can mitigate long-term complications of disease. So I'm going to go through this pretty quickly. This was some data that we presented this past year at ASH. So in medicine, I think most of us are pretty competitive, a little bit nerdy. I can say that because I'm in medicine myself. So if we've made one agent, I think the hope is that we'll always be able to do better. And so bezuclastinib is an example of a second generation targeted agent. So so exciting from a patient perspective, as now there are multiple, hopefully, options or potential for multiple options. This is a second generation agent, c-KIT inhibitor, which has been studied as part of the Summit study. This is a phase 2 study. And again, this is very similarly designed to Pioneer, whereby patients were treated with bezuclastinib at a dose of 100 milligrams a day versus placebo. And then after 24 weeks, patients who were treated with placebo had an opportunity to cross over to receive active drug. The primary endpoint for this study was a change in mean change in total symptom score, and then there were several secondary endpoints. This is a really outline of what we call the MS2D2. This was the total symptom score patient-reported outcome tool that was utilized as part of this particular study. And I wanted to put this up here just to show you the different domains that were studied. So you can look and see to the right in this part of the graph that 4 different domains were assessed. So neurocognitive symptoms, fatigue, skin, and then other symptoms, which included GI and pain symptoms. And so that really kind of covers a broad number of symptoms across the spectrum of systemic mastocytosis. And I'm going to skip that. And what we found is that as patients were exposed to bezuclastinib at 24 weeks, really a majority of those symptoms, when you looked at the change in the mean total symptom score, improved when patients were exposed to to bezuclastinib in comparison to placebo. So you will see here that there was some placebo effect, as would be expected, but the patients who received bezuclastinib by week 24 had a lot of times significant improvements in their total symptoms. And again, this was seen across symptoms and not just related to one particular symptom. So I think really exciting, again, in a disease that's associated with a lot of oftentimes morbidity and a lot of symptoms. And so if you think back to what I showed you before, circa 2003, where we had a lot of treatments that didn't necessarily impact disease or um, positively affect symptoms, these are some examples of therapies which do positively impact patients' symptoms. How about some of the biomarkers of disease? Are we seeing an impact on disease? And so I think we said before, one of the goals is to look at changes in biomarkers. And so some of those things are things like serum tryptase. So again, that's something that we measure in the blood. And as part of this study, we looked at whether or not bezuclastinib decreased various biomarkers of disease. So this is a look at serum tryptase. So this is a marker of mast cell burden. And you can see here that exposure to bezuclastinib led to a reduction of at least 50% in serum tryptase in 95.4% of patients at 24 weeks of exposure to drug. If you look at the mast cells present in bone marrow, 88.2% of patients had at least a 50% reduction in the mast cell burden, which is pretty lovely to see. And then if you look at the mutation or the mutational burden, as I tell patients, or that variant allele frequency, that also decreased nicely with 97.5% of patients achieving at least a 50% reduction. So all of those markers of disease really going down quite nicely. And so again, we saw a reduction in symptoms both with avapritinib and with bezuclastinib. We saw a reduction in biomarkers of disease, and with bezuclastinib in particular, what this slide shows is that patients with smoldering systemic mastocytosis and in patients who had previously received avapritinib, so the first generation agent, these patients also had disease responses, which I think is important. This is just a slide demonstrating some of the safety information related to bezuclastinib. This particular agent has some interesting adverse events, which we saw with a little bit less frequency with avapritinib. So if you look at the table here, you'll note that 70% of patients have hair color changes with bezuclastinib. So this is really hair lightening or whitening. This is thought to be due to bezuclastinib's effects on wild type KIT receptor. There was also some changes with taste and then some LFT changes, so AST and AST changes, which were reversible. But again, suggesting a favorable safety and tolerability profile. And this slide here is just so I remember to mention to you that as we are seeing positive impacts on bone health with avapritinib, we are also starting to see similar impacts with bezuclastinib. So again, very encouraging data suggesting long-term impacts of these agents on bone health, which is a chronic complication of this group of disorders. And so I'm going to end here so we can have time for questions. But this is really one of the last slides looking at all of the potential therapeutic targets that are being considered for patients with mast cell disorders in general. And you can see there's many, and lots of studies that are in progress. I think the questions that are going to remain are in terms of symptoms, are we ever going to get it to a point where symptoms will completely resolve? And I think that's $1 million question. And really, how do we define the optimal disease response within this group of disorders, which I think is going to be a hot topic for debate. And so hopefully that was helpful and gives you a sense that there has been a lot of progress made in the field. Again, it's been really exciting to see so many options developed for patients. And so thank you for the opportunity to talk a little bit about that.
Thank you so much, Dr. Rein. That was a lot of really good information and a lot of information. So I'm hoping that you're going to be staying for our panel
Okay.
and
Yeah.
that there will be some questions for you at the end. Are you planning to stay with us today? Okay, wonderful. That's awesome. So thank you so much for that. And I am here to introduce Dr. Ruben Mesa, who needs no introduction to this community, I am sure. And Dr. Mesa has been a longtime friend and ally of our organization here. So we're so happy to be able to host him again. And thank you so much for your time today. And it looks like you'll be talking to us about myelofibrosis.
Wonderful. Are you able to hear me okay?
I can hear you and see your slides.
All right, here. One second. Wonderful. Well, it's a great pleasure to be with you all today. We pivoted this year in conversations with Anne and her colleagues at MPN Advocacy and Education International to do this virtually, to both be able to kind of share these updates in MPNs as well as have a broader group of individuals be able to participate. My apologies, I'm not going to be able to stick around for the Q&A, and then I'm doing double duty with a leadership event that occurred for my institution, but excited to share some updates in myelofibrosis. So here are my disclosures. I've been involved with most of the therapies that have been developed for MPNs. So sometimes people ask, how does one, as a physician, get involved with the MPN community, or have been put on the path to work try to develop new therapies. And it goes way back to when I started medical school, and I was with who ended up becoming my mentor, Ayalu Teferi, who was a senior fellow at Mayo Clinic at the time. And he had offered for me as a first-year medical student to do what we call shadow, which is just really to be kind of a fly on the wall as he visited with patients with myelofibrosis. And I remember meeting a young woman in her 30s who had very advanced myelofibrosis for her age. She had a dramatically enlarged spleen, came with her family. And at the time, we really had very little in terms of options. And she ended up undergoing a splenectomy and had a very difficult time with that surgery. And it uh, really showed me the tremendous unmet need with this disease, as well as connected me with that group of individuals. And the rest, as we say, is history. Kind of working with Dr. DeFerry and colleagues at Mayo Clinic, and then many new colleagues along the way as we've tried to make this progress in treating MPNs. So as we sit in 2026, we have technically 5 approved therapies for myelofibrosis, although the first of them is one that we use very little, which is anagrelide. Primarily used as a platelet-lowering agent in ET that you heard about earlier. The 4 main drugs being 4 JAK inhibitors. My goal today is to share with you a little bit about those 4 drugs that are currently approved in myelofibrosis and whom do we consider them for, as well as some of the really promising drugs in development. Now, the key moment in trying to develop better therapies for myelofibrosis really came in 2005. That's where we had new insight into the biology of myelofibrosis through the discovery of the JAK2 mutation. And as you've heard today, the genetic changes in these diseases are important. You heard from Dr. Rein regarding the KIT mutation and other mutations in mast cell disease, and ET and PV heard about the JAK2, calreticulin, and MPL. But prior to those discoveries, we really had to use other approaches that weren't always that scientifically based. We could remove the spleen surgically because it was very enlarged. It had a lot of risk. There were a lot of complications with splenectomy. Unfortunately, this is something we don't have to do very often anymore. We used to give radiation, but that had a variety of negative side effects and didn't really change the disease. We tried to leverage observations about the disease, increases in blood vessels, drugs attacking scarring, but with really limited effectiveness. We had several therapies, that all derivatives of the medicine thalidomide, that could help a little bit with anemia. But largely, we really did not have effective therapy. We've made a lot of progress since then. And the first thing I'd mention in terms of progress is realize that not all patients with myelofibrosis are the same. This is obviously very self-obvious. You're all different individuals, different ages, different ways the disease affects you. But how the disease affects people is really quite mixed. There's risk of blood clots. We know that there's a range of symptoms that individuals can have, and those symptoms can give us clues both about the disease, but also are important targets for therapy. There's different risk in terms of progression to acute leukemia, and the genetic profile of the disease is very important. So when any of us on this call, Dr. Rein, Dr. Reeves, Dr. Coltoff, Dr. Bhave, Dr. Grunwald, when we visit with patients, we really are trying to get a sense of how they as an individual are affected. And again, if we intervene, where exactly would therapy be helpful? And we have currently 4 approved JAK inhibitors. These are all pills. They all inhibit the JAK2, which is a key on-off switch for the creation of new red blood cells, white blood cells, and platelets that is like an on switch that's stuck in the on position for patients with myelofibrosis. The first of these to be approved was ruxolitinib, or Jakafi. We now have fedratinib, or Inrebec. We have pacritinib or Vonjo, and then we have momelotinib, which is Ojara. Ruxolitinib was the first of these drugs that was approved back now 14 years ago. And it was approved because it showed that it was very effective in helping reduce the size of the spleen, helping people feel better in a way that other therapies really had not done before. Over time, we've learned as well that people on myelofibrosis or with myelofibrosis on ruxolitinib likely have benefit in terms of it extending life, possibly by making people stronger, possibly by making it less likely to progress. In fact, there have been some individuals that have lived dramatically longer than we might have expected otherwise. So it's been very helpful. It clearly has not, it has room to help even further, no question, but it really has been helpful. The second drug is Inrebec or fedratinib. And this was developed a bit in parallel. We now primarily use this drug, one, if we can't use ruxolitinib to start with, if the blood counts are relatively preserved, there's not a lot of anemia or low platelet count, and if there is not a reason that we can't use the ruxolitinib. Additionally, sometimes we use this as a second drug if ruxolitinib has not been helpful. And this was approved based on clinical trials that showed improvement in spleen and symptoms. These graphs with lines going down demonstrate benefit and lines going up demonstrating individuals getting worse. And helpful in both the front line, meaning it's the first JAK inhibitor that the patient received, or second line being the second drug that patients received. The third drug that's approved is called pacritinib or Vonjo. And this was different than the other two because it could be given to individuals with a low platelet count. And that is an issue for some, but not all patients with myelofibrosis. And it could be given at full dose, meaning one could try to get the full benefit of shrinkage of the spleen and improvement in symptoms while not adversely affecting the platelets and not increasing the risk of bleeding. This, again, these are these waterfall plots where every line represents one individual patient, and it shows there in blue the benefit of pacritinib versus the alternative therapy, best available therapy, in the gray. It also was tested in the second line, meaning, again, a second drug for individuals that had a low platelet count. The final drug approved is that of momelotinib, approved most recently in the fall of 2023. So coming up on about 3 years from that time point. And this drug was different in that it could reduce spleen and improve symptoms, but also could improve anemia or cause less anemia than ruxolitinib might cause, that can be a limiter of that therapy. And the most recent trial that led to the approval of that therapy was the Momentum study, showing compared to a comparison drug of danazol, which is an androgen, that it was better for improving spleen symptoms and anemia. So we have these four approved drugs, and people with myelofibrosis, may have been on one or more of these therapies kind of up to this point. Now, ever since the approval of ruxolitinib, there have been many different combinations that have been tested to try to add a second drug to see whether we could have better benefits. And ones that are furthest along in development include the therapy of pelabresib, which is a second drug that can almost double the improvement in terms of reduction in the size of the spleen, luspatercept, which might help with anemia, and many others that are under clinical trials at the moment. There's also a new wave of therapies that hold a lot of promise that are drugs that are more specific inhibitors of the actual core driver mutations associated with myelofibrosis. There are these type 2 JAK inhibitors, one from a company called Ajax, the other one from Incyte, and then several approaches that are specific to targeting calreticulin. Now, the four approved JAK inhibitors are likely beneficial regardless of which driver mutation an individual has. These therapies will be more specific, particularly the calreticulin inhibitors, for people who have the calreticulin mutation. So they might have a better benefit for those people, but they would not be appropriate therapy if you don't have the calreticulin mutation. Let me give you a couple examples of these. So this is the calreticulin targeted therapy. This is from Incyte, and there are ongoing studies, both at our center and many others, of using with ruxolitinib or on its own for patients with myelofibrosis. There's also, we're not going to discuss it in this talk, trials ongoing with this therapy for patients with calreticulin mutated ET. What this demonstrated was very good responses in terms of reduction in the size of the spleen. You'll see on the right side of the graph that the majority of those bars are going down. So those are signs of benefit with different lines going across in terms of the degree of reduction in the size of the spleen. Additionally, improvement in the symptoms in the vast majority of individuals. Additionally, there's early evidence of further benefit as it relates to bone marrow features of the disease, scarring in the bone marrow, and improvement in anemia. So we're starting to move to potentially a greater degree of proof of evidence of effect against the biology of the disease, which is really what we want to see. This is an exciting drug that was just presented at the most recent European Hematology Association meeting just in June, now owned by Lilly. This is AJX101. This is a type 2 JAK inhibitor. This is working to inhibit JAK in a more specific way. This is showing some of the biology in a cartoon that demonstrates that it has probably a stronger impact both in the lab, these are in test tubes, as well as had been shown in animals. Now it's in clinical trials, available at our institution and several others, showing a very significant reduction in the size of the spleen, which is very promising, as well as improvement in symptoms. All these lines going down showing improvement. It's a limited study because it's early on, but if these data hold, it would suggest that it might be more active than the therapies we've used in the past and could change the therapy that people are on. This showing changes in the genetic profile, what we call the variant allele frequency, and changes in the cytokines or proteins in the blood associated with inflammation. So where are we going? You've heard already about Vera today, and you see in lines that are solid lines approved therapies, hydroxyurea and anagrelide, ropegylated interferon, and ruxolitinib, with new therapies coming up soon, likely rusfertide for individuals that have phlebotomy needs, or perhaps these more selective JAK2 inhibitors that I just mentioned. In ET, hydroxyurea and anagrelide, we may have an approval soon with the ropegylated interferon. There are the JAK2 selective or calreticulin approaches, which may be an option. And there's numerous other mechanisms of action that are being tested. And in myelofibrosis, again, you see in the solid lines, hydroxyurea, anagrelide, Rux, and the other three JAK inhibitors, all approved. And then things coming up on the horizon, ropegylated interferon for early disease, the more selective JAK2 and calreticulin inhibitors, JAK inhibitor combinations, and yet even other mechanisms of action. What I'll share with folks is I would view this, one, I would be hopeful. There are many therapies in development that may be beneficial for you. Two, I realize well that there can be, when one sees all this, kind of that FOMO, that fear of missing out. Am I missing out by not being on one of these experimental therapies? Always good to talk with your physician. Are you on the right therapy? The role of clinical trials is primarily for individuals where our current therapies are not being beneficial. If you are stable, let these clinical trials play out, because if the drugs are better, then over time it'll be appropriate for you to switch. The role of trials is when our current therapies are not doing what they should be for you. So with that, let me thank my colleagues. Again, we will be having our MPN workshop at the Carolinas starting this weekend. All this started back when we had our Texas MPN workshops. As you see from the many names on these slides, clinical investigators, laboratory scientists, MPN foundations and advocates such as Anbrazo and MPN Advocacy and Education International. It really takes a village to make a difference. And certainly I'll share with Ann and colleagues that you certainly can have access to these slides. None of these things are confidential. I know we've gone through them quickly, but hope that they're a resource for you. Thank you.
Thank you so much, Dr. Mesa. And yes, those slides, thanks for sharing that we have access to those, because I know that you condensed your talk here today. So we will share those slides with whoever is interested. And without further ado, and so that we can keep Dr. Grunwald's time in mind as well, we will let him present now. Thanks again for your time on evolving role of transplantation.
Perfect. Thanks, Natalie. Am I in the presenter mode, or am I in kind of the personal display mode right
You
now?
are in the personal display. We can
Okay,
see.
let me
Yeah.
flip it. Okay, is that better?
Perfect.
All right, excellent. So, hi everyone. I'm going to talk in about 6.5 minutes to try to stay on time today about the evolving role of transplantation, cellular therapy, and bispecifics in MPN, mostly focusing on transplant. I do have a number of disclosures that I am sharing here. So, the intent is very, very quickly to give a flavor of a few different topics. What is a transplant? When do we think about transplant? What is the process? What are the potential benefits, the risks, the complications? Have we made transplants better? And can we in the future make transplants better? And then kind of a final question that I added here is what new transplant or transplant adjacent therapies might be coming. So allogeneic transplant, which is in this kind of purplish color here, the middle curve, it's been increasing over the years. There was a slight dip during COVID, but in general, the number of allogeneic transplants in the United States is increasing year by year. And part of this has to do with the fact that it used to be hard to find donors for transplant, and now we have more different types of donors, and finding a donor is generally not an issue. When we are doing a transplant from somebody else, we usually can find a donor for a patient. Now, transplants are done for a number of reasons. Acute myeloid leukemia is the most common reason for an allogeneic transplant, meaning a transplant from another individual. And we can see here MPN transplants are not super common. They're somewhere between 500 and 1,000 per year in the United States, but it is one of the top causes or one of the top reasons for allogeneic transplants. And so there are 3 steps in an allogeneic transplant. We get cells from a donor, and then we give the recipient chemotherapy with or without radiation to suppress the immune system of the recipient. And then we give the recipient the cells from the donor. And what we want to happen is we want the donor's cells, the donor's immune system, to attack the cancer, usually myelofibrosis when we're talking about MPNs. We want it to attack the myelofibrosis of the recipient, and then we want the cells from the donor to repopulate the bone marrow of the recipient. And so we want the donor T cells, these are donor immune cells, to attack the leukemic cell, or you can sub in MPN cell over here for leukemic cell. And what we don't want too much of is we don't want these donor T cells to be attacking the epithelium of the recipient. This is the normal cells of the recipient. If we get too much of an immune attack from the immune system of the donor on the body of the recipient, this can cause damage to the skin, the liver, the intestine, and other organs as well. This slide is depicting acute graft versus host disease, which occurs in the first few months usually after transplant. And then there's also a type of graft versus host disease called chronic graft versus host disease, which mimics some chronic inflammatory or autoimmune disorders. We also worry about infections, viral infections, bacterial infections, and fungal infections after transplant. And these do occur relatively commonly, and we try to prevent them. And if they arise early or late, we try to detect them as soon as they're happening and then treat them appropriately. So when we think about who needs a transplant, it's mostly myelofibrosis patients within the MPN group. We look at the patient's genetic factors, their clinical factors, and we try to risk categorize patients and determine, is this disease bad enough to warrant the risks, the infectious risks and the graft versus host disease risks of the transplant. If we look at our guidelines, it is higher risk patients. So usually patients toward the higher end of the intermediate risk spectrum, and also patients with high risk myelofibrosis who are targeted for transplant. Our guidelines say these patients, if they are fit enough for transplant, should undergo transplantation. And then we also have patients who have so-called accelerated or blast phase MPN. These are patients whose MPN is turning into more of an acute leukemia type of picture. And these patients, if they are candidates for transplant, are recommended to undergo transplant or at least have transplant considered as part of their therapy. And so again, just depicted in a cartoon here, we want to think about transplant early, but it's really these patients, not the ones with ET, not patients with PV, but it's patients with myelofibrosis, sometimes patients with MDS-MPN overlap that is mimicking myelofibrosis, who have intermediate risk disease or above, in whom we want to consider transplantation. And then as we get into accelerated and blast phase disease, these more acute leukemia type MPNs, we want to be thinking about transplantation. So if we think about the process itself, we collect the cells from the donor, and while we're doing that, we want to try to control the disease of the recipient as much as possible. We want to control the spleen size. We want to test the organ function of the recipient to make sure the individual is healthy enough. We give chemotherapy with or without radiation to the recipient to immunosuppress him or her, and then we administer the cells from the donor. Afterwards, we have low blood counts, patients are tired, and we watch out for bacterial and fungal infections, which are common. And then as we get into the second month, oftentimes the blood counts are starting to get better. Sometimes patients are still requiring some transfusions. Patients are doing a little better, feeling a little better overall. They will sometimes get viral infections, and we're also watching out for graft versus host disease. And then as time goes a little bit on into the third month, patients hopefully are requiring fewer blood transfusions. We check a bone marrow to see how the bone marrow is looking, and maybe it's looking better at this point. We are watching for viral infection still in graft versus host disease. So kind of an overall schematic that does not apply to every individual, but applies to many. So over the years, we have gotten better at transplants. We have less intense conditioning regimens, so less intensive chemotherapy and radiation. We can give older or less fit patients to make transplantation safer. We have more options for donor, and we also have better ways of preventing graft versus host disease. But still, we can do better. We can understand relapse better and ways to prevent relapse better. We want to understand the molecular genetic underpinnings of disease a little bit in a little bit of a better way to be able to predict relapse and target patients who are at high risk for relapse with methods that might prevent recurrence of disease. And a lot of this work has to do with coming up with ways to try to maintain remission after transplantation. And then another factor with myeloproliferative neoplasms, including myelofibrosis, is the spleen. Many patients have enlarged spleens. The enlarged spleen is a risk factor for rejection of a transplant. And so we really want to do what we can to shrink the spleen prior to transplant, whether that's with a JAK inhibitor like ruxolitinib or sometimes radiation. So when I'm thinking about transplant in a patient and discussing it with a patient, I am thinking about how the patient feels about it. I want their thoughts about the transplant. It's not usually a unilateral decision. It's a discussion with the patient and his or her caregivers. I want to know what's important to him or her. Does transplant have a role in this patient's disease? What other health conditions does the individual have that may complicate transplant? What is the appropriate timing of transplant in a particular patient? And this is probably the trickiest part. And then, is a transplant safer now than it will be later as a patient ages and might develop more diseases, or when the myeloproliferative neoplasm is more advanced and might be harder to control? Will we lose that window of opportunity for transplantation? And so these are all things that we think about a lot and discuss with our patients and discuss with colleagues as well. And kind of as a final thought here, we have new cell therapies that are under development to try to target antigens or try to target abnormalities in patients' cancer. And these have come a really long way in lymphoma. They've come a long way in a disease called multiple myeloma. And they've come a little bit of ways in some leukemias, like acute lymphoblastic leukemia. We're a little bit behind in the MPNs because it's been harder to find targets that are on the disease and not on normal cells. But there has been excitement recently. We have some therapies in development, including bispecific therapies. And bispecific therapies are treatments that are trying to bring immune cells, T cells, close to tumor cells. And this one from Johnson & Johnson is a bispecific therapy that is trying to bring cells with CD3 on them, so these are T cells or immune cells, close to tumor cells that have a CALR mutation that we've heard about already. And the thought is, if we get the T cells attacking the cells that have a CALR mutation, maybe then we can eradicate the disease. And this idea, this thought, gives rise to, well, what if we could use a CAR T cell therapy or a genetically engineered T cell to fight a CALR mutation and maybe other mutations in the future as well? And so I think this is where a lot of the research in MPNs is going, into directing immune therapies against specific abnormalities in MPN cells. We're a little behind other diseases, but quickly catching up, I think. And with that, I will leave you. Unfortunately, I'm not going to be able to stay for a panel discussion, but I look forward to interacting with many of you on this call at a later time. And I work frequently with MPN Advocacy and Education, and I'm sure there will be other chances.
Most definitely. Thank you so much, Dr. Grunwald. And as he mentioned, we are running a little bit behind today. Just all of our specialists have so much to share with us, and we want to make sure that they give you all of the information that they can. So that being said, what we're going to do is if you can continue to put your questions and answers into the Q&A box down at the bottom of your screen, we're going to collect those and make sure that we have a response that would go out via email. We'll post it on our website and also on our YouTube page and Facebook page, all of our social media, so that you can get some of the answers to the questions that you are asking directly here. So we're actually going to move right on to hear some information from our industry partners who are going to share the most cutting edge information about their current therapies available to you for your myeloproliferative neoplasm treatment. So we're going to begin with Insight's Lauren Green, who is going to share with us, if she is available. There she is. Hi, Lauren.
Hi, how are you?
Great, thank you. So I'm going to go off screen and let you take it away.
Perfect. Well, hello everyone. My name is Lauren Green. My role at Insight is as an oncology clinical educator, and I'm so happy to be here today and would like to thank the MPN Advocacy and Education International for letting me share a little bit about Insight's commitment to the MPN patient community. So Insight is a global pharmaceutical company that is headquartered in Wilmington, Delaware, and our mission is to solve on, which simply means that we follow the science to develop breakthrough medicines to improve patients' lives. By partnering with groups like MPN Advocacy and Education, we're able to better understand the needs of the patient and the healthcare provider communities, which helps to inform how we advance science and support the communities that we serve. Patients are at the center of everything that we do: patient access, product development or clinical trials, and our educational programs and initiatives. Insight Cares is our patient program or patient support program that's established to help patients understand insurance coverage, explore financial assistance options, as well as provide resources and as-needed support. We do recommend patients enroll early in their diagnosis, even if they don't anticipate needing assistance. But if circumstances change, enrollment will enable us to help more quickly. And you can visit insightcares.com for more information. In the area of development and clinical trials at Insight, we solve on to bring advances for those with unmet needs across hematology, oncology, and inflammation and autoimmunity, including dermatology. Excitingly, we are preparing to enroll eligible patients in clinical trials testing novel targeted therapies for MPNs, specifically phase 3 studies of investigational therapies in myelofibrosis and essential thrombocythemia. We also recently received FDA approval for a once-daily formulation of our standard of care therapy for certain adult patients with myelofibrosis, Polycythemia Vera, and certain adult and pediatric patients with acute and chronic graft-versus-host disease. Innovating to provide patients and their physicians with choice and flexibility in managing their treatment options is one way we continue to solve on. We are so grateful for the people who have participated in our clinical trials, as well as the caregivers who support them. And if you are interested in participating in a trial, please reach out to your HCP and visit our clinical trials page at insightclinicaltrials.com. We actively support the MPN community with educational resources like Voices of MPN, which provides MPN information and tools, patient stories, and community events, and you can discover more at voicesofmpn.com. And finally, our annual awards program called MPN Heroes, it's now in its 14th year, and this honors individuals and organizations that are committed to improving the lives of patients impacted by MPNs. You can learn more about this program and our heroes at mpnheroes.com. And in every role at Insight, you'll find people who take pride in the opportunity to make even a small contribution to the health of people living with MPNs. So thank you so much for inviting me to discuss our passion and our work, and more so for the partnership that we've had with MPN Advocacy and Education International. Thank you so much.
Thank you so much, Lauren. And we encourage anyone who's interested in getting more information to go to that website. Um, Now we will hear from Abby Gill from Pharmacentia. Hi, Abby.
Hi, thank you, Natalie, and thank you all the doctors who are on the call today, and Anne, and obviously the organization for putting together this wonderful webinar to support all of the MPN patients. My name's Abby Gill. I'm the senior manager of patient advocacy here at Pharmacentia. At Pharmacentia, our goal and our company is really dedicated to treating patients and supporting the MPN patients across all disease states. We have some really wonderful resources online and digital that are available to all of you. Our MPN podcast is in its second season called Stories from the Marrow. You're going to hear from patients, caregivers. We're going to hear critical scientific updates and more information on what's going on in the MPN community through that podcast. That can be found on platforms like Apple and Spotify. And then we also have our Piece Together PV, which is just an online resource to support all of the patients in PV through their self-advocacy, better outcomes, and those are amazing resources online to support you through those hard conversations with your doctors. We have a downloadable symptom tracker, lifestyle tips, educational resources, and new, we have Piece Together ET. And so also similar, helping you with that self-advocacy piece, symptom trackers, lifestyle links, and being able to track them, and as well as making sure that you have a treatment goal that's going to work for you and obviously in tandem with your doctors. So you can find all of that online by just Googling the Stories from the Bone Marrow, Piece Together PV, or Piece Together ET. But again, thank you for this time. Pharmacentia is here to support all of you in your MPN journey. And thank you, Natalie and Anne, for this opportunity.
Thank you, Abby, for the update. And now we'll hear from Serge Verstosvik from Cartos. Serge, are you here? There he is.
I'm here. Hello.
Hello.
Hello, nice to see you. Well, thank you everybody for a lovely symposium, and thank you for organizing to have us or me on the call. It was lovely to see Dr. Ruben Mesa, I have to say that, with a lovely picture at the end of his presentation with MPN meeting that he organized in San Antonio in Texas in 2022. I was actually the tallest guy there. I'm not the tallest guy, but I was on the photo, so it was kind of funny. This is to say that since then, I joined Cartos, a small biotech company, as a chief medical officer, and I retired from clinical practice at MD Anderson Cancer Center in Houston. And now I'm supervising what you can see here, a POIESIS study. That's a phase 3 randomized blinded study with the medication called navtemadlin as a new therapy in combination with ruxolitinib. If you just Google POIESIS myelofibrosis trial, you will get to it. This is a study that seeks patients with myelofibrosis that need therapy with the JAK inhibitor that are to be given ruxolitinib. We assess on the study patient situation before they start ruxolitinib. They have a questionnaire to fill out to see how their symptoms are. We measure the size of the spleen, and then patients on the study are given ruxolitinib for 5 months. Ruxolitinib is standard first-line therapy for patients with myelofibrosis, so we just follow the standard practice. And the study is done around the globe in 23 countries in more than 250 clinical centers. After 5 months of ruxolitinib, we know that patients, and I published on that as well as many others, patients get what you get in terms of the benefit and in terms of the toxicity. Everything is resolved within first few months. By 5 months, we know where we are with the ruxolitinib benefit. Then we ask the question, is there a group of patients that have some benefit from ruxolitinib, but we can help them to improve that benefit, so-called suboptimal responders? That's a substantial group of patients that benefit from ruxolitinib, but there is still presence of the spleen that bothers the patient. There is still presence of some symptoms. Again, we call the patients like that suboptimal responders. Continuation of ruxolitinib in standard practice in these patients will maintain that partial suboptimal response for some time. However, we of course are not happy with that clinical situation for these patients, and therefore suboptimal responders to ruxolitinib are then randomized to receive naftamarlin on top of ongoing ruxolitinib dose or placebo for next 6 months. This is how we help patients that need help, that have a benefit, but suboptimal benefit from ruxolitinib, and we help those patients to optimize their care from suboptimal to optimal care with the addition of naftamarlin on top of ruxolitinib. So very simple study design. If you look through perspective of the patients participating in study, patients that have not been treated with ruxolitinib or any other JAK inhibitor so far, but need help with that therapy, the JAK inhibitor therapy, they are enrolled on the study. For 5 months, they receive ruxolitinib alone, and then randomized to receive naftamarlin or placebo on top of ongoing therapy with ruxolitinib to optimize their care. After 6 months of randomization, we see about the benefit. Please look it up. This is the only study with naftamarlin, the only study within CARTAS ongoing at the moment. And we hope that in a very near future, we will be able to celebrate the success of the study for approval, possible approval of naftamarlin to help our patients globally that have suboptimal response to ruxolitinib. Thank you very much for having me on the program.
Thank you, Serge, so much for joining us. And lastly, we'll speak with Chris Tankersley from Prelude Therapeutics, a new partner of ours. Welcome, Chris.
Thank you very much. So pleasure to be with all you, and it's been an excellent discussion so far. And so I'm happy to kind of introduce Prelude Therapeutics and one of our ongoing trials. We have initiated a trial late last year. It's PRT 1239601. It's a phase 1 open label multi-center safety and efficacy study of PRT 12396 in participants with polycythemia, Vera, and myelofibrosis. So for those who don't know about Prelude Therapeutics, so we are also a clinical stage biotechnology company based in Wilmington, Delaware. We're led by our Chief Executive Officer and founder, Chris Vadi, who is largely credited with the discovery of ruxolitinib many, many years ago. So PRT 12396 is our investigational therapy designed to selectively target the JAK2 V617F mutation, which, as was discussed earlier, is a key driver of mutation in patients with polycythemia vera and myelofibrosis. So in our trial, this is again a first-in-human phase 1 study. So we're hopeful that our therapy can be shown to basically improve on the treatment that has been started with Jakafi ruxolitinib, and the goal of basically, hopefully, maybe being disease modifying in these two patient populations. So, as a first-in-human study, our first kind of responsibility is to understand the safety and identify the appropriate doses of PRT 12396 to study further in subsequent trials. And in order to do that, we have to basically evaluate, the target that we're hitting with the PRT 12396. So we're ultimately looking to see if we can engage the target and then see what the effects on the disease are ultimately in the patients. So looking at blood counts, spleen sizes, symptoms, and then using all that data to basically decide whether we should advance to a larger clinical trial of PRT 12396. The study is ongoing. We enrolled our first patient at the end of April. The study is basically built around two patient populations. So one group is those patients with polycythemia vera who are high risk and they previously received a prior cytoreductive therapy, as well as a myelofibrosis patient group that have intermediate or high risk primary myelofibrosis, but they could also be patients that had post-PV MF or post-ET MF, the so-called secondary myelofibrosis patients. Those patients had to receive a prior JAK2 inhibitor, and again, resistant or refractory or intolerant to that prior treatment. The study is going to be enrolling about 100 patients. We have two parts. One part is a dose escalation part, where we'll evaluate subsequent doses, higher doses, until we find a recommended dose that we could take to part two of the study, a dose expansion, where additional patients would be enrolled. There are about 25 sites globally spread between the US, Australia, France, Italy, and Spain. So if you would like additional information, you can look up the study on clinicaltrials.gov and just look at PRT 12396. And with that, I will just say thank you very much to the MPN community. And then I think importantly to recognize the patients who participate in clinical research, without whom, their time and commitment, we cannot understand and develop new medications to further benefit the patient population. Thank you.
Absolutely. That's a good point, Chris. And thank you for sharing. We look forward to hearing more from you and more about this clinical trial, which we will also be sharing. This video will be posted on all of our social media sites, including YouTube, and we get many viewers who come back. So this information is not just being shared here today, but will continue to be shared. So thanks for that.
Excellent.
Thank you to everybody who participated today. We ran a little bit over, but I'm glad that we were able to have this time together. And just a quick reminder that we do have some upcoming events. We will have another webinar on Friday, September 11th. At 12 o'clock Eastern Standard Time with Dr. Aaron Gertz, who's going to give you from Cleveland Clinic, who will, give an overview of MPNs and answer any questions that you may have. Also, please join us for the 12th annual Women in MPN Conference, which will be held virtually by popular request. That is Friday, September 18th from 9 a.m. till 12 p.m. And again, thank you for your time today, and we look forward to continuing the conversation with you, and enjoy the rest of your day.
Thank you.
Thanks so much.